Good afternoon to you all. Shall we start the meeting? First, I will introduce Dr. Amila Ratnapala, who is joining with us today for the talk. Dr. Amila currently working as a consultant respiratory physician at Langmill General Hospital, Carmarthen, United Kingdom. And he previously worked as a consultant respiratory physician at National Hospital, Kandy, Sri Lanka. He is currently engaged in collaboration research with the Oxford University Hospital and some studies in Sri Lanka, mainly in the area of interstitial lung disease. He has several publications related to interstitial lung disease, which I am not going to elaborate now. As he is a very good has very good understanding on laboratory setting, as he worked in collaboration with laboratory while he's here during the COVID period, and also while he working at UK. So I cordially invite Dr. Amila to start his presentation.
Good afternoon. First of all, I'd like to thank Dr. Dulani for the invitation, and also that for the College of Chemical Pathologists for inviting me for this presentation. I wish you can hear me as well as you can you see the screen as well?
Yeah, all clear. Yes.
Good. Right, so today I'm going to discuss about the pleural effusions. How do you approach clinically to pleural effusion? So my objectives of the talk is today, it's about to describe about what is pleural effusion and what are the potential causes for pleural effusion and what are the different types of pleural effusions. And then to discuss about how do you approach clinically to a pleural effusion, and then I'll be discussing cases based on differential diagnosis. So what is a pleural effusion? It's accumulation of pleural fluid, as you all know, between the parietal and visceral pleura. Even in a healthy individual, that there's a small amount of pleural fluid, less than 50 ml, and it facilitates the movement of between the parietal and visceral pleura during the normal breathing. And there's a delicate balance of pleural fluid in a normal individual. It produces by the cells in these pleura, and then it has been absorbed by the lymphatic vasculature in the pleural cavity. So there's a delicate balance, and unfortunately, if there's any imbalance between these equilibrium, and then it will cause accumulation of pleural fluid. So if I summarize that, as we can see in the pleural cavity, and there's a parietal pleura, which is the outer layer, and the visceral pleura is the inner layer. And if there's any increased production of pleural fluid due to various pathologies, so if there's a decreased absorption due to various pathologies, that it can cause pleural effusions. So this is the physiological aspect of pleural effusion. As you can see, this is a capillary bed, and this is the inflow, and this is the outflow, where the blood comes in here and blood comes out there. And then there's a osmotic pressure, which is gradient about 35 millimeters of water, which is causing fluid to go out. And there's oncotic pressure because of the proteins inside, or albumin inside, which is causing fluid to absorb in. So therefore, this equilibrium is very important to maintain the adequate amount of fluid in the pleural space, and this excess amount of fluid is usually absorbed by the lymphatic drainage system. So when there's pleural effusion, we should know what are the types of pleural effusion. As you know, there are transudative and exudative pleural effusions. We're using two criteria to diagnose this. The commonest one is the Lyse criteria. There are three criteria, as you know. If the pleural fluid protein to serum protein ratio is More than zero point 0.5, we know that is due to capillary increased capillary permeability, and that is exudative effusion. And if it is less than or equal zero point 0.5, that we know it is due to increased capillary hydrostatic pressure or reduced capillary oncotic pressure. That is a transudative effusion. And also we use LDH if the LDH is if the pleural LDH to serum LDH is more than zero point 0.6, that is again suggestive of increased capillary permeability causing exudative effusion. And if it is less than zero point 0.6, we know it's a transudative effusion. And also if the pleural fluid LDH is more than two-thirds of the upper limit of the normal serum LDH, that is also suggestive of a exudative effusion. So various infections, inflammation, malignancies, and autoimmune causes, all these causes can lead to this exudative effusions. Organ failures, which is commonly cardiac failure, liver failure, or nephrotic syndrome, or renal failure, these organ failures usually lead to transudative effusions. But there are certain instances that we might not be able to use the lights criteria. For example, if the patient is on diuretics for longer duration, if the patient is having persistent organ failures like congestive cardiac failure. So in that case, this light criteria might not be very accurate. In that instances, we are using this serum effusion to albumin gradient that is known as SEEG. And if the gradient is less than 1.2 grams per deciliter, which is suggestive of exudate, and if it is more than 1.2 grams per deciliter, that is more suggestive of a transudate. So we are using in certain instances this SIG in addition to the lights criteria. So we are basically differentiating whether it's a transudative effusion or exudative effusion. If we consider the causes, there are many causes, more than 60 to 70 causes of pleural effusions. The commonest are, exudates, and we see frequently in malignancies, parapneumonic effusions. The less common cause of exudates include pulmonary infarct due to pulmonary embolism, rheumatoid arthritis, and other autoimmune diseases causing serositis, which usually cause bilateral effusions and sometimes pericardial effusion, and also benign asbestos effusions. Pancreatitis is again another cause, and we see post-myocardial infarction syndrome or the Dressler syndrome, and the rare causes include yellow nail syndrome, drugs, and various fungal infections. If we consider transudates, as I mentioned previously, commonly due to organ failures, which include left ventricular failure or liver failure, hypoalbuminemia due to various causes, either due to nephrotic syndrome or malnutrition, and patients with peritoneal dialysis. Less common causes include hypothyroidism and mitral stenosis and all, and very rare causes include constrictive pericarditis and urinothorax, and superior vena cava obstruction and ovarian hyperstimulation. So how do you approach pleural effusion clinically? So again, when you're suspecting pleural effusion, the most important aspect of your clinical assessment is a history, because even at when you're processing a laboratory investigation, it is very important to have a brief history about this patient. So what is the chronological order of this disease? For example, if it is a gradual onset and persistent for about months and months, it could be due to a malignant pleural effusion, or it could be due to a chronic infection like tuberculosis. And it could be sudden onset pleural effusion, as we see in Dressler syndrome or post-myocardial infarction syndrome, or due to pulmonary embolism causing pulmonary infarcts and pleural effusions. And we should ask about the risk factors, whether the patient is having any other risk factors, like whether he's a smoker or whether he has any exposure to asbestos, and whether the patient has any history of any family history of any malignancies and all. And also we should ask about the exposures, various medications, as well as various inorganic or organic dust exposures. And the examination is also important to diagnose pleural effusion. And then we go for imaging. The basic imaging is chest X-ray, and then we'll do a bedside ultrasound scan to assess. Ultrasonically also we can differentiate certain effusions, whether it's exudative or transudative, and then we do the basic other hematological investigations. Then only we go for a diagnostic and or therapeutic aspiration, and then we are differentiating whether it's exudative or transudative effusion. And after that, we do specific investigations to diagnose a specific condition. So basically, we initially take a history and examine the patient and do imaging, and then do a diagnostic with or without therapeutic aspiration. And initially, we differentiate into either transudative or exudative effusion. And after that, we'll use specific investigations to diagnose the specific condition. Current shortness of breath with pleuritic chest pain for 4 months duration. And he's breathless, and the chest pain is more with menstruation. The examination revealed there's a stony dullness with reduced breath sounds in the right lower zone. Do you have any other clinical differential diagnosis this patient? Right. Okay. So this is the X-ray. We did the initial X-ray, as you can see here. There's homogeneous opacity in the right lower zone. The left lower zone is normal. And there's possible linear atelectasis and fluid in the horizontal fissure. So we did ultrasound scan, and then we did a CT scan of the chest. As you can see here, in the right side, there is a pleural effusion, and the lung is collapsed, and there's evidence of pneumothorax as well. So we did a diagnostic aspiration of this patient, and we found the pleural fluid protein is 41 gram per liter, and glucose is 3.1 millimole per liter, and the pleural fluid pH was not done on this patient. And then we did the pleural fluid LDH levels, which is 221. And when you compare the serum protein levels, as you can see, serum protein is 69. And so therefore, when you go back to the pleural fluid analysis, we know that this is likely a exudative effusion with low glucose. And so therefore, we in the history, from the history, we know that it is catamenial. It is more associated with menstruation, and therefore we went ahead with this algorithm, and we did diagnostic aspiration. We found its exudative effusion, and the cellularity was mainly its blood-stained fluid. And then we decided to proceed with the thoracoscopy. So this is a thoracoscopy that we do medical thoracoscopy in our setting under local anesthesia. So we directly went to the pleura and then visualized the pleura and took some biopsies. And we found these hemorrhagic areas in the pleura, and the histology was confirmatory of pleural endometriosis. There's extensive hemosiderin-laden macrophages and chronic inflammation and fibrosis, and features are suggestive of endometriosis of the pleura. So this is one of the classical example that we see, not very common, though, of pleural endometriosis of this patient. We started with basic investigations. The second patient is 76-year-old male, presented with gradual worsening of breathlessness for 2 weeks duration. He's a ex-smoker, and he smoked about 20 pack years of cigarettes, but has been stopped smoking for about 10 years, and he was working in a farm. So this is his X-ray, as you can see here. There's right-sided homogeneous opacity, and there's some pleural thickening here, and the rest of the lung fields are fine. And so we did a CT scan of the chest of this patient, and we found that there's quite a significant amount of emphysema. So this patient has been an ex-smoker, so there's quite a lot of emphysema, and then a large pleural effusion with pleural nodules. So again, we did a diagnostic aspiration of this patient. We did pleural pH, and which is 7.45, and we did usual pleural fluid proteins 47 gram per deciliter, and then the pleural fluid glucose or 5.5, and when you compared with the serum values, and we found that it is exudative effusion, but the pH was normal. Uh, so pleural fluid analysis, I mean, it's really important. We do pleural fluid pH quite commonly in our setup, but in Sri Lanka, we know that it is quite difficult to perform because, uh, most of the blood, and we can do the pleural fluid analysis in a blood gas machine and to assess the pleural fluid pH, but most of the centers, they do not use because our resources are really limited to assess the pH. But in laboratory analysis, actually we can do the pH, but some of the laboratories, they do have the facilities to do the pH, but we should send this in a heparinized syringe within 1 to 2 hours to the laboratory. That is very important. So in this patient, as you know, that the pleural fluid is exudative, and therefore we had we from the imaging, we were suspicious of a possible malignancy, and we did a thoracoscopy again for this patient. So our case approach, we did the clinical assessment. We took a detailed history of this patient, assessed the risk factors. Patient has been smoking for a while, and we did imaging, and then we did diagnostic aspiration, and then we found it's exudative, and then we use a specific investigation, which is thoracoscopy to confirm the diagnosis. There is a thoracoscopic appearance of this pleural effusion. As you can see, there are multiple nodules in the pleura causing this exudative pleural effusion. So when you go to the next case, is a 76-year-old lady with cough and weight loss and appetite loss for about 1 month duration. And she has been diagnosed with diabetes with poor glycemic control, and she's coming with cough, weight loss, and appetite loss for about 1 month duration. So we did a basic evaluation, and then this is the initial imaging. As you can see here in the chest X-ray, there are multiple opacities, including cavities in the lung fields, predominantly in the left side, and you can see the left cosphenic angle is obliterated. There's a possible effusion, and so we proceeded with a CT scan of the chest. As you can see here in the left side, there are multiple cavities with fluid levels, and there's a pleural effusion in the left side as well. So we did our basic analysis. We did a pleural fluid proteins, which was high, and the LDH was high. It was a lymphocytic, and serum protein was compared to serum protein and serum LDH. We know it is exudative effusion. And in this patient, again, we did a case-based approach. We took a history, and there are risk factors like diabetes, and imaging is suggestive of cavitate relations with pleural effusion, and we found it's exudative effusion. And we did, in addition to the routine investigations, we did pleural fluid ADA levels, which was 97, and we did a MON2 to assess whether the patient has any exposure to tuberculosis, and the sputum smears, which was negative. So I'd like to highlight this specific investigation, which is quite useful in our local setup, which is adenosine deaminase. It's an enzyme produced by the lymphocytes and involved in purine metabolism. And it is extensively studies biomarker, but it is very specific for the pleural fluid. And we know I have seen that we are requesting sometime ADA for CSF. And sometimes we are requesting ADA for peritoneal fluid, but it is not validated as it is for the pleural fluid. So it's a very good biomarker for the pleural effusions. And what is the most important aspect of it? Because when these lymphocytes, when they're exposed to tuberculosis and they secrete this ADA in higher amounts. So if it is a lymphocytic effusion with higher ADA, that is very suggestive of tuberculosis. So when there's a clinical suspicion of tuberculosis pleurisy, and we do a diagnostic thoracocentesis, and if it is a lymphocytic exudate and negative for cytology and there's no other evidence of malignancy, if it is more than 70 units per liter, that is suggestive of tuberculosis. If it is 40 to 70, that is possibly associated with tuberculosis. And if it is um, less than 40, that is, we know the sensitivity to be diagnosed as tuberculosis is very less. So we use this quite commonly, but it's unfortunate it's not very frequently available in the government sector, but it is available in the private sector. Again, we have to uh, uh, I mean, depending on the affordability of the patients, that is a very useful investigation, especially when there's a clinical suspicion of tuberculosis and when it is a lymphocytic exudate. The next patient is a 55-year-old patient who has been admitted with shortness of breath for about 1 week duration. And he had chills, but there's no fever. He has background history of alcohol-related chronic pancreatitis, and he has portal hypertension and gastroesophageal reflux. So this is chest X-ray. As you can see, there are bilateral pleural effusions, and in the left side, there's a cavity with a pleural fluid accumulation. And we did a CT scan. You can see the bilateral effusions in the left side. There are multiple complex pleural effusions with cavities. So we did a pleural fluid analysis. The pleural fluid protein levels was 23 grams a liter, and then protein glucose level is 5.1 millimoles per liter, and its pH is 7.39, and the lactate level, lactate dehydrogenase level is about 115. So when you compare that with the serum, as you can see here, the serum protein is 60. So if we take the ratio, it is 23, and the LDH levels are less than 50% of the normal value. So we know it is a transudative effusion and it is non-acidic. And we did the specific investigations, and we did a serum amylase levels was significantly elevated, as well as we did the pleural fluid amylase levels, which was significantly elevated. So in this patient, we confirmed that the diagnosis is related to pancreatitis, and it is a pancreatic pleural effusion. When the pleural fluid amylase levels are elevated significantly, um, and that is either suggestive of pancreatitis, or it could be due to esophageal rupture, and we can see that uh, in these patients they have high amylase levels in their pleural fluid. And my next case is again a bit rare, but I decided to discuss about that because it is important. It's a 38-year-old lady who presented with shortness of breath for about 10 months duration, and she has undergone nephrectomy 2 years back for a renal tumor. And we examined the patient, and we found that reduced breath sounds in the lower zones of the lung, and she has been previously investigated for renal tumor. There's no family history though. So we did a chest X-ray. As you can see, there are multiple cystic opacities in the lung, and we did a CT scan of the chest. As you can see here, there's a right-sided pleural effusion, and there are multiple cystic lung disease, multiple cyst in this patient, of cystic lung disease. So we did a aspiration of this pleural fluid. As you can see here, it is almost like a milk appearance. And we did investigations which include pleural fluid protein was 31 and pleural fluid DH was 118. It's a lymphocytic, and the serum protein was 70. It's a transudative effusion, and there was no atypical cells. And the pleural fluid triglyceride levels was elevated. It's 165, and pleural fluid cholesterol levels was 80, which is less than the serum cholesterol levels, and pleural fluid glucose 120 milligram per deciliter. So, diagnosis of chylothorax, um, we use the pleural fluid triglyceride level if it is more than 110 milligram per deciliter, and the ratio of pleural to serum triglyceride level more than 1. And the ratio to pleural to serum cholesterol level should be less than 1, and lipoprotein analysis of pleural fluid we might see the chylomicron. But we are not doing this lipoprotein analysis commonly in chylothorax. So these are the cases that I thought of discussing, and I'm sure that if there are any questions with regard to these cases or any other with regard to the analysis of this pleural fluid, I'm very happy to answer for any questions. And thank you so much for listening to me.
Thank you, Amila, for very informative discussion. I think the forum is open for questions from the audience. Are there any questions? Now you can raise the questions for Dr. Amila. Amila, I have a question.
Yes, please.
Yeah, regarding the pre-analytical phase in UK practice, is the guideline for the collection? Are there any protocol? How you should proceed with the patient with pleural effusion? What is the investigation that you should perform? Basically, is there any like clinical care pathway guided procedure?
Yes, so basically, I mean, we have a diagnostic algorithm for pleural effusions. I mean, basically, once a patient's coming with a pleural effusion, and usually we do as I said, we do the initial analysis, and then we do a ultrasound guided aspiration, and mainly within 1 hour, we do this diagnostic aspiration, and then we send the pleural fluid for analysis. And our main investigation is to exclude infection in the pleural space in acute setting. So we do the pleural fluid pH, and then we send the rest of the pleural fluid for analysis. So, but I mean, usually within 1 hour, we are planning to do a diagnostic aspiration if the patient coming with a pleural effusion, and we try to send all these investigations within 1 hour. Especially the pH to exclude infection, because if there's infection, if the pH is less than 7.2, we usually go for a therapeutic aspiration or either pleural fluid chest. We go for a chest drain to remove the pleural fluid.
For the pH, you are sending the sample in the heparinized tube in ice, same as for the blood gas analysis?
Yeah, so we are using, we are sending the pleural fluid in a heparinized, so we use the same blood gas analysis syringe for that. And it's a heparinized syringe, and we use a syringe, and we send the syringe, and because we are sending within 1 hour, and we are not using any ice or anything like that, and we are sending as soon as possible.
Yeah, they are using the blood gas analyzer or the main analyzers in the laboratory.
So in our practice, actually, they are using the laboratory analysis. But in certain instances, actually, if the laboratories, I mean, not functioning, or I mean, if there's a delay in the laboratory, we can always send the sample for the blood gas analysis, and we do the we run pleural fluid in blood gas analysis in some occasions where if the lab is not processing it, usually in the nights and all. But commonly we use our lab support with acid pH analysis during the daytime, but at night time, or I mean sometimes in the weekends, we run in the blood gas analyzer.
Yeah, the problem that we encounter here is when you get the cell count, that there is a complaint that samples are clotted when received to the laboratory. Do we have a different experience in UK?
Usually, actually, that I think that most of the time, when you send the samples, and if it is a pure frank pus, I mean, if it is frank pus, so if we clinically diagnose this as a kind of a empyema, in that case, we don't send for pH, because that we know that it has a very high risk of it is clotting and all. But usually, if it is frank pus, or if it is suggestive of empyema clinically, we don't send for pH analysis. But otherwise, if it is clear fluid, and if it is, I mean, if you don't, if you're not suspecting it to be clot, in my experience, we haven't experienced much pleural fluid clotting in the laboratory, because we haven't received any issues with that.
Okay, thank you very much. Any other questions from the audience?
So I'm from Delhi. Is there any role of pleural fluid amylase in the pancreatic pleural effusion?
Yes, so as I discussed in the case, actually, that we do pleural fluid amylase levels especially when you're suspecting patients with pancreatitis. So that is highly useful analysis that we can do in pleural fluid to diagnose pleural effusions related to pancreatitis. Yes.
Any other questions in the chat? Yeah. Any other questions? Okay. In the absence of questions, I invite Dr. Dilanti, Secretary of the College of Chemical Pathologists, to deliver the vote of thanks.
Thank you, Dr. Dulani. I hope that you all can hear me. Good afternoon. First of all, let me thank Dr. Amila Ratnapala, Consultant Respiratory Physician, for delivering a very interesting and an informative talk today. Thank you, Dr. Ratnapala, for joining with us today and sharing your knowledge amidst your busy schedule. So, Dr. Ratnapala, a token of appreciation will be sent to you in due course. Next, our sincere thanks go to all the participants who joined with us today to make this event a success. So I hope you will have gained knowledge regarding this analysis of pleural effusion fluid, and we hope to see you all in another interesting webinar like this next month. So thank you. Have a nice day.
Thank you so much.
Thank you. We lined up the meeting. Thank you. British policy guidelines development in 2016 is positive and negative.